Well, hello. This is chapter 5 in your positioning book, and we are continuing with scapula. Now, this particular image shows some of the anatomy of the scapula, and this can be found on page 180. So there are 3 borders to the scapula. We have the superior border, which is up top. We have the medial or the vertebral border, which is closer to the spine or closer to the vertebrae. And then we have the axillary border or the lateral border, closer to the axilla. Now, when we look at this anatomy, if we look right here, this picture, or this A, represents the acromion. Actually, I'll just put this picture separate and we can look at that. But this is the vertebral or medial border, represented here by E. G represents the lateral or the axillary border. And then the superior border isn't outlined, but that would be up top here. Is the superior border. And then right in here, we've got the inferior angle of the scapula that we use for chest positioning. Now, when we look at the front or the anterior view of the scapula, you can see you've got the acromion process, which articulates with the acromial end of the clavicle and forms the AC joint. You've got the coracoid process right here, which is used for shoulder positioning, the scapular knot, superior angle. This is the medial or vertebral border. This entire thing here is the body of the scapula. Inferior angle, the costal surface or the anterior surface, also referred to as the subscapular fossa. This would be the lateral or the axillary border. Then you've got the neck of the scapula, the lateral angle, the glenoid cavity or glenoid fossa right here. Quite a few parts on such a little thin bone. When we look at the back side of the scapula or the posterior view, you've got the supraspinous fossa up here. You've got the spine of the scapula. And then this is below the spine fossa or infraspinous fossa. So supra, above the spine, little divot in there, and then below the spine, the infraspinous fossa. And this is the dorsal surface or the posterior surface of the scapula. And again, this is the acromion process out here. So this is axillary border, this is vertebral border. When we look at the scapula in a lateral view, as far as radiographically, we can look at the parts of this. So this is the Y view. And remember I told you the parts of the Y when we looked at this before for the shoulder. A is the acromion process. B is the coracoid process, the foam, the top of the Y. And then we come together and bring those down. And then E is actually the body of the scapula. And then we said the humeral head ideally sits in the center of that. And then that would mean there's no dislocation. So as far as parts of the scapula go, A is the acromion, B is the coracoid process, C is the inferior angle of the scapula, or the very bottom portion of the scapula. D is the scapular spine running right here, and then E represents the body of the scapula. And then you can see it again right here showing you in anatomical terms, and then this would be radiographically. So this is actually what you're looking at in this image right here. If we look at the anatomy of an AP scapula, and this is the image that we had before, you can see again, A represents the acromion process, B is the scapular neck, C is the suprascapular notch. D is the superior angle of the scapula. E is the medial or vertebral border because it's closer to the spine, which is over here. F is the inferior angle of the scapula. G is the lateral or the axillary border. And then H represents the glenoid cavity or the glenoid fossa, where the humeral head sits to form the shoulder joint or the ball and socket. And then again, lateral scapula, this is the anatomy that we just looked at. And this is actually one of the positions that I'll show you for the lateral scapula. But this one is actually done to demonstrate the coracoid process and the acromion process better, with the patient's arm is down behind her back. All right, now when we look at a scapula, there are actually only two views to a scapula. There is an AP and a lateral. So on the AP scapula, this is found on page 207. And with most things that we've talked about this week, we've said that the patient can be erect or supine, but typically when you're talking about the shoulder, the scapula, AC joints, things like that, it's much easier on the patient if they're able to be upright. There's not as much pressure placed on that anatomy as when they're supine. So usually the patient preference is to be erect for these images versus supine. Now, on the AP scapula, this is to look at any pathologies or fractures of the scapula. The scapula is a very thin bone, very painful if it's broken, but the injury would have to be pretty much direct to the scapula or like a fall flat back on the back. I've seen them break their scapula that way. The patient can be shielded. Again, erect is more comfortable for the patient, so you just have them stand with their back against the board. Kind of want to center the scapula of interest to the center of the chest board. And you want to abduct the arm 90 degrees and supinate the hand. And what this does is it moves the scapula more laterally, and it clears more of the thoracic structures when she brings her arm out like that and then supinates her hand on her head. So bringing this action of bringing the arm out pulls the scapula more lateral, and then supinating the hand like that just clears it of more structures. The central ray is perpendicular to the mid-scapula, which is 2 inches below the coracoid and 2 inches medial from the lateral border. Now, technically, according to the registry, that's where the central ray is mid-scapula, which is 2 inches below coracoid, 2 inches medial from the lateral border. But ideally, if you go about 3 inches below mid-clavicle, that would put you about center scapula. So 3 inches below mid-clavicle is just a good cheat. Technically, central ray is mid-scapula, but as far as how you find that, about 3 inches below the middle of the clavicle would put you there. Now, for this, we actually use a breathing technique, or that orthostatic breathing, which you set a low MA, a long time, typically a minimum of 3 seconds, to equal 5 mass. And what that'll do is allowing the patient to breathe during the exposure will blur out the ribs and the lungs so that you visualize the scapula much better. So again, 80 kVp at 5 mass with a breathing technique. And when that image comes out, you can see the entire scapula. You've got the superior border, medial border, inferior angle, and lateral or axillary border, glenoid, all of the anatomy of the scapula. And notice how it's pulled kind of clear of some of the thoracic structures, not as much midline. And the lungs and the ribs are kind of blurred so that you're actually seeing the scapula through that. The lateral border of the scapula should be free of the ribs and the lungs. And because you allowed them to breathe and do that orthostatic breathing, you're able to visualize much more of the scapula than if you didn't have them. If you had them hold their breath, you'd see the ribs and the lungs much more pronounced than we do in this particular image. If you notice on that last positioning, they have the marker down low here. That's acceptable. Also, if you had a little bit of light field up here, you could also place it above. But you can see where they placed it has it coming out right here. Personally, it's a little bit close. I'd prefer it up here, but either way is acceptable as long as you're marking the correct anatomy. Then radiologists don't really care. Now, the lateral scapula is the next view. Now, this particular image, this is figure 5.96 on page 208. The AP, if I didn't say it, was on page 207. But this particular positioning where she has her hand on the opposite shoulder, this is going to demonstrate the body of the scapula much better by doing this kind of positioning. Okay, so the central ray again is to the mid-vertebral border, approximately 2 inches from the top of the shoulder and 2 inches from the lateral border. The patient's going to reach across the front of their chest and grab the opposite shoulder in order to demonstrate the body of the scapula. Right? And for this particular one, you would use 80 at 7.5, and the patient can just suspend their breathing. And notice how with that arm crossed over like that, this body of the scapula just pops right out free of all other anatomy so that you could visualize any fractures in there, any misalignment taking place. It's a really nice image. Now, you also can do, if, like we said before, if you're trying to demonstrate the acromion or the coracoid process, what you do is have the patient bring their arm down and back behind them. So her hand is actually on the small of her back. And what this does is demonstrate the acromion process and the coracoid process much better. Notice the still some obscuring of the body of the scapula by the anatomy of the arm, the soft tissue, and that's okay, because this, when you position the arm like this, where you bring it back behind and put it on the small of their back, you're actually looking for the acromion or the coracoid process. Okay. So you're actually looking more in this area, the acromion process right here, coracoid process. All right, so that's a lateral. There also is a recumbent lateral scapula. Now, notice with the recumbent lateral how much OID there is between this shoulder and the table, because she's on a 45-degree angle sponge. So this is going to result in magnification because of the increase in OID. What you would do is roll the patient's affected shoulder or scapula up, elevate that side, and then you want to palpate the body of the scapula. So you're going to try and grab the medial and lateral borders of the scapula and make sure that you roll the patient up until the body of the scapula is actually perpendicular to the IR. And then once you have it perpendicular to the IR, you center about mid-scapula. Probably about 3 inches, 4 inches down from the top of the shoulder. So body of the scapula perpendicular to the IR, and then centering to the middle. You're probably collimated on this at 10 by 12 lengthwise. This is how some of the techs do their Y views for shoulder. Remember I told you they do AP Y views, but it's not really recommended for the shoulder. But this is actually what they do. This is what it would look like, but it results in an increase in OID. So this shows the body of the scapula in profile. Okay, so it's nice and superimposed. You see the body free of superimposition, and then the arm is actually elevated to demonstrate the scapular body. Right? So now that one doesn't look very magnified, but if you truly position the patient like this into this image, this would be much more magnified than what's demonstrated here. All right, again, AP and lateral scapula. The AP is done with a breathing technique or orthostatic breathing, where you set a low MA and an increase in time, approximately at least 3 seconds, so that you will allow the patient to breathe during the exposure, and it'll blur out any lung and rib anatomy so that the scapula shows through. That is done for the AP. And then the lateral is done the exact same way as we do the Y lateral for the shoulder, except we move the arm out of the way by having the patient grasp their opposite shoulder. And remember, that demonstrates the body of the scapula much better. So they grab their opposite shoulder, and it demonstrates the body. Most of the time when you're imaging the scapula, they're usually suspecting injury to the body of the scapula. Like I said, when patients fall flat on their back, if they pass out and fall flat on their back and complain of pain in the scapula, that is a potential that there is a fracture or shattered scapula. So that's what they're typically doing, this positioning, when you're looking for that. If they were looking for the coracoid or the acromion process, then you would have them bring their arm, bend their back, and put their hand on the small of their back, and that'll demonstrate the acromion process and the coracoid much better. So AP and lateral scapula found on pages 207, 208, and then this one is on 209, the recumbent lateral scapula. And that brings us to the end of the scapula anatomy and positioning. And we will discuss this during one of our live sessions.